So I will be presenting here my journey from Arvind to KSF, 2D life aiming for 3D future. I just want to share my journey from Arvind over here, over past 5 years. So hi, I am Dr. Avik Dey Sarkar. I am senior consultant and vitreoretinal surgeon in Kamala Sundaram Eye Center. I have done my MBBS from Nilratan Sarkar Medical College and MS degree from Midnapur Medical College. I have finished my long-term vitreoretinal fellowship in Arvind Eye Hospital, Madurai. So these are my few early days in Arvind. This, I think the photo in the right side was the first day when I reached Arvind. It was a very early morning. We used to have we used to start very early in the morning, like 5:36. We used to go to our clinics. By 6:30, the footfall used to start. And this, the photo in middle is my introduction period to the Arvind and to Orolab. This is a photo of our diabetic retinopathy screening camp. So it was a simple but useful screening camps for diagnosing diabetic retinopathy and all other retinal vascular diseases. Arvind used to do both the cataract and diabetic retinopathy screening camps, where more than 250 plus diabetic patients used to be catered, and over the period of years 7,000 patients used to be catered. This used to help in discovering population with unknown diabetic retinopathy related changes and complication, and providing early treatment for the same, because many of the patients never used to come to the hospital. It was from a very outreach areas. So we used to go over those areas. It used to be 100, 200 kilometers away from our base hospital, and we used to cater to those population. So what are the biggest life lessons I have learned in Arvind? First is, it's more than the medications. It's your empathy that heals the patients better. A kind gesture, few words of sympathy, and an affectionate care serves more to the patients. It is not always the biggest of the medications or biggest of the surgeries always heal the patient. It's more how you treat them, how you see them, how you feel for them. But at the same time, it's an organizational values and structural robustness that makes you self-sufficient and more productive in catering to the mass population of the society. Simple, stepwise procedures help in making a giant empire of healthcare that can serve millions. Also, to set a goal in achieving perfection, one should be very clear regarding his goals and passions. The more you nurture your area of interest, the more you become confident and competent. So never to stop learning unless you have learnt it well. We used to discuss over there over different cases, different intriguing facts, everything. We used to deal with retina all day long. This was my degrees that I have received over there. But does learning stop over there? Definitely no. So we used to go for publications, publishing in the best of the journals. Some of them are definitely very close to my heart, because we have given a lot of time, lot of research for all these publications. And finally, I got an international recognition in ASRS conference in Stockholm, Sweden, couple of years back. In the recent accolades, I have received the appreciation certificate for one of my articles from IJO, and I have been awarded as the distinguished contributor for JVRD publication from American Society of Retinal Surgeons. But still, I genuinely believe my happy place is my operating room, where I used to spend most of my time over there, and I would love to spend the same over here also to cater most of the patients. I just want to show a couple of my surgical videos in short. So this was a GRT RRD patient. It was a complex surgery because already the patient developed PVRC changes. So, and we can all see that we can see very well over here, the retina is crumpled even in the middle of the posterior pole. So wherever it was almost a complete bare choroid. So we started nudging all the pre-retinal membranes all over the retina. And on the posterior pole, we have tried settling with a PFCL bubble. Although I have not given a large PFCL bubble because it was going through the choroidal region, subretinally. So initially I did not want to give a large PFCL bubble. So we started managing the PVR membranes. We can see the pre-retinal membrane is coming in toto. As I have removed the pre-retinal membrane, so I have given a little larger PFCL bubble. And with the help of the Thanos DDMS forceps, I was trying to flatten the retina, which has been already crumpled over that region temporally. With after BBG staining, we started doing ILMP, and I genuinely believe all the PVR cases it is better to do an ILM peeling, because we have seen in most of our cases that if PVRC and all those things happen, usually those patients are tend to form ERM in a very recent soon course. So it is better to do the ILMP on the first go only. We usually do not do it on the second time or anything. We usually do it in the first go only. And we usually prefer it doing under PFCL. After ILM peeling and thorough base shaving, we have started the fluid air exchange. We can see the bare choroid area temporally. That much of retinal shortening was already there. And finally, after settling the retina, the case was closed under silicone oil. This is another case of macular hole with RRD. In the same way, we can see the PVD has been induced. In many of these cases, actually, the regular PVD induction is little difficult because of anomalous PVD and all. The PVD is the last sheet of vitreous is usually quite adherent, so it is better to go for forceps. Sometimes we use Thanos also. For it depends on the ease of the surgery, whichever instrument we are particularly using, whether it helps or not. So after removing the vitreous membranes, we are trying to settle the posterior pole with PFCL, and we can still see that in the periphery, in the mid periphery, the vitreous membranes are still over there. If we don't address those vitreous membranes, it will just keep on causing more PVRC in the post-op period. And we used to believe over there, a person who knows to manage one hole can manage even more than one holes. So we never used to be afraid of making a single one or two extra holes, iatrogenic maybe. But we always used to believe that the PVRC changes, all the pre-retinal membranes and the vitreous should be dealt very well, because those are the reason why again the PVRC, because of the PVRC re-RD happens. And here we have given we are stained with blue, and the macular hole area we are covering with inverted ILM flap. Usually for all these cases, we like to do arcade to arcade peeling as large as possible. But for normal macular holes, as a routine procedure, we used to follow that at least 2.5 size of the hole size, that area of ILMP should be done around the hole. And if the hole size, we used to do beyond 600 micron, if the hole size is, we used to do inverted ILM flap. So after after apposition of the flap, we have done the laser and the case is closed under silicone oil. He was my first international fellow, did ROP training under me. He was Dr. Ahmed. He was from Tanzania, and he would have been, like now he is practicing ROP over there. He is the first ROP surgeon and ROP specialist from Tanzania. He's been trained in Arvind. So it was a little pride moment for all of us that we have actually led a country start ROP management over there. Then why shifting to Kamala Sundaram Eye Center? So the values and the ideas Arvind has taught me over the years, it was time that I should apply to another population where it is needed. In such a big metropolitan city like Mumbai, where businessmen to film stars rule the society, a large part of people still can't afford adequate healthcare. Here, under the able leadership of Dr. Natarajan sir, I felt I can achieve the dream I have seen all throughout eye care service for all. His Blind Free India movement resembles very closely to the lessons we have learned in Arvind, Dr. Venkat Shami sir's mission of needless blindness. I have performed a surgery over here. This is a simple CRVO V8 surgery, but we can understand, this talk is more about of Seeluma. This surgery we have done it over here under Seeluma guidance. The machine is brilliant. We can understand the clarity of the recording and everything, and the same picture we could have seen inside also. It was actually very helpful doing the surgery. So it was a simple vitreous hemorrhage case in a CRVO. Already all the vessels were seen sclerosed intraoperatively. We can see the sclerosed vessel over the temporal arcade. So a thorough vitrectomy has been done, not only to clear the posterior pole, but also to clear the as periphery as possible in order to decrease the PVR changes as well as to decrease the chances of NVI in future. As we can see, there is a large clot or chunk of blood on the posterior pole. So over there, what we used to do is we used to use a 1 cc cannula. The same trick I use over here also. We used to take a 1 cc cannula and we used to fill it up with saline for half cc, and we used to do a gentle jet over the posterior pole, over the bleed. So it actually helps in clearing the vitreous hemorrhage over the posterior pole. The jet should be controlled so that it should not hamper the macular anatomy and integrity, but it should be again little forceful enough so that it dislodges the clot. With practice and precision, this becomes very easy. So we can see over here the clot has been dislodged from the posterior pole. So just for as an institutional teaching, I always use tricot in all my cases. Just for the sake, we have seen a lot of cases where we have thought that the PVD is already induced. It's a brilliant case, but after giving the tricot, we have realized there is a second membrane or there is an anomalous PVD lying over there. So we as an institutional teaching, I always use tricot. And under PFCL, usually for CRVO cases, I usually do ILM peeling under PFCL, because I genuinely believe the inner retinal part is usually very thinned out in all these retinal vascular occlusion cases. So while doing the ILMP, it becomes the retina appears very friable. So I usually use PFCL. So after the thorough ILMP and clearing the vitreous, we have lasered all throughout, all 360 degree. And finally the case was closed under silicone oil, under SF6. Thank you for adhering to my talk. I would like to ask you to wish for us for our better future, and let this institution can cater most of the patients in a well-mannered fashion. Thank you.